ask that the live stream is started?
Madam Chair, can confirm the live stream has now been started.
Thank you. Welcome to this meeting of the Health and Wellbeing Board being held today, Monday the 13th of March 2023. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and proceed to the assembly area in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. To ensure that recording quality is maintained, please speak as clearly as possible and keep background noise to a minimum. Please ensure that mobile phones and other devices are turned to silent. Others are permitted to film, photograph and record our public meeting, providing that it does not disrupt the business of the meeting. If there are any members of the public present, which we haven't got, who do not wish to be filmed, raise your hand, but there's nobody. Voting will be undertaken by show of hands in the room only, and the online virtual committee members will not be allowed to vote. We have a number of people in attendance as virtual participants. Can I request that they use their raise hand function within the system if they wish to contribute? It's going to be tricky now. Somebody's going to have to keep an eye on the hands behind me. So, item number 1 on the agenda. Have any apologies been notified to the clerk?
Councillor Tyler and the applicant to give their apologies.
Thank you. Any named substitutes?
I believe it's Helen Wayne, the superintendent.
She's down there.
Oh, Gillian, representing Mike.
Thank you. Item 3, declarations of interest. Do any members wish to declare a Schedule 1, Schedule 2 or other interest in any agenda item? No. Item number 4. The minutes of the meeting held on 26th of September are included in the agenda pack, pages 5 to 12, and they are for approval. What I would like to add is that on the first page, there is an error because board members were present for voting.
Yeah.
And that was everybody bar Ed Williams, who was remote, so he did not vote. So that's an adjustment, please. Thank you. And I think there's another one which David Mahaffey wants to add as well, please.
Does this work? Yeah, it does. Also, can we note Simon Trickett's apologies for the meeting as well? I didn't get my hand up in time for this meeting. Job titles in the list of participants need to be updated to reflect some changes in from the CCG to the ICB and a couple of other roles. So I'll communicate those separately.
Thank you. Thanks, David. So therefore, I move that the minutes subject to the amendments be signed in the correct record. All in favour? Thank you. Item 5 is questions from members of the public. Do we have any written questions? Thank you. And item 6 is questions from councillors. Thank you very much. So we'll move swiftly on then to item 7, which is an amazing piece of work from the public health team, and it's the health and wellbeing strategy. This is the draft copy for us all to review and make comments on. So I'll hand over to Matt and Mary.
Thank you, Chair. So I was going to take you through a presentation, but in the interest of time, I thought I'd just give you a brief overview. Hopefully recognising that many of you had the chance to read the 2 documents that were attached with the agenda. So those 2 documents were the draft health and wellbeing strategy itself and the draft engagement report from the engagement activity that we undertook during kind of November, December, towards the end of last year. So I really want to emphasise at this point that this very much is a draft strategy, and the reason for bringing it to the board today is to invite comments on that draft strategy. We're engaging with a number of different providers and partners and stakeholders over the next few weeks, and we have done for the last 2 weeks to get their views to help shape it further. So actually when we come with the finished product towards the end of April at the next Health and Wellbeing Board, we'll be in a position to sign that off as a strategy for the next 10 years. So I'm just going to give you a very brief overview in terms of what's contained within that strategy, feeding back some of the engagement activity that we've done, and Mary can chip in if needed in terms of any questions you might have and to elaborate further. So the strategy itself, as we identified, is a 10-year strategy. The board met back in June last year, and there's a number of principles that they agreed on in terms of developing the strategy. And we're currently revisiting those principles to make sure they do reflect what the board wants. And then we also had a workshop earlier this year as well, based on some of the feedback we have from the consultation activity to inform what this strategy looks like. And we also need to remember how this integrates with the integrated care strategy, which David might have some comments on as well, making sure that the strategies align and work together. So in summary, we've been on a bit of a journey. We've done a lot of work getting to this point from June last year. We've looked at existing strategies, we've looked at the epidemiology data in terms of what the data is telling us, how we benchmark to other areas across the country, regionally, and our comparative areas. We looked at other strategies, as I said, across the council and wider system, and then we've done that public engagement that engaged on 12 different priorities during the end of last year. In terms of the feedback that we did, we had a really good response to our consultation activity. We had nearly about 1,000 people respond to the online survey, and we undertook 14 focus groups, and these are engaged in a range of different audiences, particularly the seldom heard, the ones that we know that are disproportionately affected in terms of health outcomes, and that's reflected in the report. So overall, we were relatively pleased with the amount of engagement, activity and responses we got. We felt there was actually a good response from previous consultations that have taken place in Herefordshire. There's more detail within the engagement report. I think the common themes that came out of the engagement activities are actually everyone felt that all of the 12 priorities were really important, and actually you couldn't really argue against any of them. However, the two that really came high across the majority of age groups, demography and seldom heard groups, was every child had the best start in life and good mental health throughout the life course. So those are the two priorities we decided that actually the health and wellbeing strategy should focus. And we had a discussion with you may remember, earlier this year about the board wanting to focus on those two areas. And actually that aligns with the board wanting to have more focused, a focused kind of effect on this strategy this year, rather than have a broad breadth of different things to focus on. There are other comments that we need to think about in terms of what residents fed back as well. And again, some of these would be very common to Herefordshire and some you would have heard before. So in terms of residents wanting better access to information, local and county-wide, there is concerns around access to GPs, dentists and other health services. And again, we'll be familiar with some of those challenges that we're facing, particularly during some of the pressures we're experiencing. And they talked about transport, the issue around access and transport and mobility coming through too. Residents talked about help with the cost of living crisis, childcare, and they also want to see more focus on prevention, community safety, and equality and diversity. So those are some of the common themes, and that's something we probably need to think about in terms of taking this strategy forward, in terms of have we really reflected those thoughts from the residents, but at the same time balancing what we know about the data and what the information is telling us where those issues are within Herefordshire. So in terms of the principles for the strategy, there's some principles we've identified within that strategy that we think are really important, that guide all the work we do. So we almost look through a lens of everything that we do across the county. And again, some of these will be familiar and also align with the integrated care strategy. So it's about a prevention first approach. So we talk a lot about prevention. What does that mean? What does that look like? We really need to focus upstream. It's about community empowerment, and we've got an item further on the agenda today around a community paradigm, and that completely aligns with us. How can we have a different relationship with our communities, building on the great work the Talk community are doing, really engaging with them, working with them as equal partners so they co-design the services that we do. Reducing inequality is also on the agenda today. So again, how do we look through that lens of inequalities through all that we do, recognising that some people are disproportionately impacted, and how can we make sure we support them as much as we can. Workforce, again, a very common theme, how we've got a strong valued workforce. Integrated ways of working, again, building on the work that we're doing through One Heritage Partnership and other services. It has to be evidence informed, we really need to guide what we do, the data, what works, and then focusing on outcomes and monitoring the impact. Some of the reflections we had from our last health and wellbeing strategy is that it's quite difficult to articulate what that overall impact was on that strategy. So going forward, we really need to document those outcomes and making sure we're refining and doing that continuous improvement. So there's a diagram, I can't remember what page it is in the papers, and apologies, but it almost illustrates our kind of vision. Our primary priority is best start in life, good mental health and wellbeing, and we've actually identified a number of secondary priorities. And the reason we call these secondary priorities, actually we think these are equally important as a primary priorities, but actually they're kind of the wider determinants work that we know is so instrumental in terms of shaping people's life. So we don't want to just focus on lifestyle behaviours, but it's like housing, it's like the economy, it's like the built environment, the natural environment, and all those things that make us, who we are today and support our health and wellbeing. So really what we want is this strategy. It's almost keep a watching brief on those priorities. It may be delivered through other partnerships across the county to understand how they're influencing our health and wellbeing. And then we've got our goals as well, where we talk about thriving communities, opportunities for healthy people and healthy and sustainable places. We also talked in the strategy about what does a priority mean, and I still think that probably needs a further conversation. So actually, what difference would that be being a priority? Is it like more, we as a board spend more time on it as a priority? So actually, we spend some dedicated sessions on it. We have some regular reports to the board to actually report back on those priorities and those outcomes are being delivered. And it's about having a detailed delivery plan and a costed plan. Again, that was a reflection of the last strategy, was around governance. And actually, we need those detailed plans underneath so we can track and monitor progress. So I won't go through the detail. The two priorities we've started to shape out what best start in life means and what those high-level outcomes are. And we've also done the same for mental health across the life course. I do want to emphasise, because it is a 10-year strategy, we're very much starting with high-level outcomes at this moment in time. The next step, once the strategy has been ratified, is we'll be delegating that to the partnership group to sit beneath the board to co-develop those detailed action plans that sit underneath, making sure we align with existing work back within the integrated care system and within the primary care networks as well. So that's certainly where the detail will come out, but we wanted to at least emphasise what are those key level outcomes we want to achieve going forward. There's a table within the strategy as well that talks a little bit about how we deliver these ambitions across the system. So against those two primary priorities and the six supporting priorities, is actually where does some of that work already sit? So for example, reducing carbon footprint, that actually came out quite high in some of the consultation. We know there's some good work around the Climate Action Partnership Board. So again, it's understanding what work they're doing and making sure that's supporting the health and wellbeing agenda. And we know there's some win-wins with regards to that. Same with things, good work for everybody. The council and partners recently published a big economic plan. So we know there's some good work in that, and actually within that strategy, there's some key objectives around health and wellbeing of our workforce. I mean, that's a key challenge for us in Herefordshire. So I won't go through all of those, but again, we just need to work through how we understand that interface between those different subgroups. We've included the high-level outcomes framework within the strategy as well, so it documents the high-level outcomes we want to achieve, strategic outcomes, the primary outcomes and the secondary outcomes. Again, we need to refine that over the coming weeks to make sure we really understand what that impact will be. We recognise some of these changes will take time to deliver. So again, that's why the detailed action plans underneath will be really important. Finally, governance. There's a little bit about governance in there. We've been having some conversations with James, who's One Heritage Partnership, and colleagues about actually who owns this strategy going forward in terms of the operational side of that. We've had some early conversations that could be One Heritage Partnership that actually has oversight and holds those delivery groups for account. But we need to work that through the coming weeks to make sure we're all comfortable with that arrangement, recognising that might be a slightly different way of One Heritage working for those meetings where it might be 4 times a year to actually bring in those partners to understand the impact of that strategy. So next steps, ongoing consultation with partners. As I said, it's sign off on the 27th of April. We've also scheduled some feedback sessions with the public on the 28th and 30th of April, so almost like we listen to you, this is how we've responded to your concerns. But as with this strategy, there's going to be continuous engagement with the public going forward, and that's really important. That's it from me, I'll stop talking now. Please take any questions.
Thank you, Matt. Very comprehensive strategy, this. What I'd like to start off with is that I really do applaud the engagement and consultation that you've taken to a huge amount of people. And I think it's one of the ones that I've seen the most responses to. So obviously, you've done a good job. Thank you, Mary. I know you've been out there arranging these as well. And also, these identified principles run through the whole of today's agenda, to be honest. So I think, if we're starting off on this foot, I think, everything that we're doing as a local authority and a public health team. So thank you. Okay,
Chair, so Councillor Hitchener has a question.
all right, thank you. Councillor Hitchener.
Yeah, my apologies. I can't be with you in the room this morning. I can't see who else is there. It was quite interesting to me reading this. I mean, first of all, I think it's a great document. It's very readable. I think it looks very good. One thing which really struck me a little bit, which might be kind of my friend. Sorry about this. It's on page 10. It refers to the preventative approach, prevention and early intervention, and it talks about the kind of obvious things. Maybe this means taking action to help prevent problems arising in the first place, whether that might be identifying difficulties that a new parent may be having with a baby. And it goes on and said, or an issue that an employee is having with housing rent. And it just struck me that that's sort of going down to quite a low level, but it is about the whole community getting behind this. It's people who are in the workplace who identify that someone is having a problem paying their rent, and instead of ignoring it, think, well, what can I do about this? What concern is there? It's just one sentence in the whole document, but it really struck me as being potentially quite an important element of this strategy. It's not about just the council, the police, or the NHS doing it. It's going right down to the fundamentals of our society. And I don't know whether, Matt, you wanted to comment on that.
Yeah, I'm happy to. Mary might want to, because I think she inserted that specific phrase. I mean, the primary, secondary, tertiary prevention is an interesting one, because I remember I was on a call with a CMO and he said, actually, if you get 100 academics in the room, you'll never agree with what primary, secondary and tertiary prevention are. We all have various different definitions and interpretations. Primarily, the three definitions are associated with health, and it's very much focused on preventing disease. If you identify disease early, you can intervene. What we wanted to do is actually try and frame the three tiers of prevention across kind of the wider sense of health, like you say, Leader. So it's about those things in terms of housing, the environment, and how people live their lives. We might not get agreement on all of these, and I know there's some really good work that Venture are doing around primary, secondary and tertiary prevention as well. So we're just trying to encapsulate kind of a broad definition that we understand that actually prevention can be at any part of somebody's life course at any stage. It's never really clear cut as what we've set out there. It's all just us thinking a bit more upstream, like say, whether it's about housing, whether it's the economy, whether it's the environment. May, I don't know if you wanted to come in on
No, I think you've said it, Matt, really. We wanted to reflect the fact that the well-being is wider than just your physical health, and because all these things in your environment are going to have impact on you. So you might not be able to work properly if you can't pay your rent and you're worried about being thrown out. And then it impacts on your mental health, and then impacts on all the workforce. So I just put that in there because I wanted to show that we're not just thinking about someone's disease process. Yeah.
Thank you, Mary. Any other questions or comments? Christine, then Mary.
Yeah, I just had a question about where you think the mental health priority will be driven at the next stage, Matt. Thinking about, we've got various structures, where you think it's going to be, the work will get done.
Yeah, and I think that's what we need to work through, Christine. So we've identified three partnerships, if you like, that are delivering on the mental health agenda. So the ICS Mental Health Collaborative, that we know is doing a lot of work at system level. My understanding is they're doing a lot of work around the NHS long-term plan. And then here in Herefordshire, we have 2 local mental health groups. So we have the Adult Mental Health Partnership, and we have the Children and Young People Emotional and Wellbeing Partnership, I think it's called. So obviously they cover the adults and the children. So I think there needs to be a conversation about how we deliver that priority through those existing partnerships. I think we need to think that through, because they are 3 different partnerships, and often things are intergenerational as well. So again, this is another argument I've come across in my past before. Splitting mental health into children and adults isn't always helpful, just because of the intergenerational aspect of mental health outcomes. But we do through those 3 groups, and I think we need to develop that conversation and refine that over the next few weeks so we get that right and understand what they're already doing as well. I think there's some concerns that actually those groups could be more effective, and it's how we as a board kind of put our weight behind it, I think, so kind of making a difference.
Yeah, and then the second point was about the existing work parts of the document. I think there's probably more that needs adding from other partners in that. At the moment, it probably does mostly reflect local authority work, and I'm sure there are some other things, so I'm happy to help. I know Mary's asked me for some input on that. I think we could all do with having a look.
Yeah, no, I think that's really helpful. I think we have engaged those programme leads. I think the case studies we could probably do a bit of work too. I think the challenge we've got, we want to keep it short and concise, but we also want to reflect all the great things that are already going on in Herefordshire. It's kind of that fine balance, isn't it? But we welcome the help.
Thank you, Christine. Hilary?
I think it's a really good strategy. I just had some concerns about language. So on page 37 of the agenda pack, or page, what page it is, where we talk, I think that language of secondary priorities, it makes it sound like they're second best, but actually those ones are really important in terms of delivering the primary one. So I just wonder if we could think about the language of that, because I think it creates a divide, which I don't think is, so that, you know, good mental health does depend on having housing and all the rest of it. So I think there's something for me. And I think the other bit is, I just wasn't clear what we meant by our goals. So we've got priorities, and then we've got goals, and then we've got principles. So I just think there's a little bit of reflection we could do around, because I don't know whether the goals supersede the priorities or the priority. I think there's just a bit we can just unpick there that just makes it a bit clearer.
Any other comments or questions? David?
I think there's fair points. I think the issue about the secondary priorities is probably about supporting or enabling priorities, isn't it? Because it's the same issue we dealt with when we were developing the integrated care strategy, and recognising that to give children the best start in life, it's as important that they're born into a good home, to parents who've got a good income, etc., etc. So they're not separate, they're not secondary, as you said. They're things that enable us to deliver that on those core ones. So maybe calling them supporting or enabling areas, like something like that might help. Yeah, I mean, other than that, it's really good to see the strong link across to the integrated care strategy, which we would expect to see anyway, wouldn't we, given all the close work we've done on this. But very supportive of the overall approach, and good to see the outcome measures being defined as well. As you say, one of the challenges to the last one was working out exactly what the strategy achieved, but if we define really clear outcome measures, then we know what we're aiming for, don't we?
Any other? Diane, Councillor Toynbee.
Yeah, thanks, and thanks everybody for the work on this. It's really great to have it. My question is about waiting lists, because probably a lot of us hear from residents that you know, what I hear from residents is that that's what they're most concerned about, having to wait for an appointment, wait for diagnosis, wait for treatment. And, you know, we all know people who've died while that process has been going on. So how much can we do locally about reducing waiting lists, and how much is beyond our control?
Probably go to David on that one. I mean, it come through very strongly in terms of access to GP services, but I don't know if that links to the NHS Forward plan, David. Would it be okay to come to you on that one?
No, you can come to me. I don't know whether Jane wants to.
Or Jane.
Sorry, come in on some of this. I mean, it's, you know, I think it's fair to say it's the #1 NHS priority at the moment. Look through all of our plans, we're producing something which is a delivery called the Joint Forward Plan. it absolutely sits front and centre on there. Yeah, a couple of years of pandemic really put us behind. We've got some very long waits, but we are working desperately hard to bring them down as quickly as possible. And I mean, Jane might be able to share some of the detail about some of the programmes that you're doing locally, but definitely a very high priority for us, and doing all we can.
Yeah, certainly up there. I mean, and it's fair to say Herefordshire went into the pandemic with higher than average waiting times. But actually the last couple of years, and a lot of that was really about capacity. So lots of beds in the hospital, so therefore we have to keep using our elective surgical beds for emergency patients. And also not enough theatres in the hospital. So there was lots of work that was outsourced into other areas. So people went to Wales, some went to Droitwich, some went to all over the place. All of that made it really quite difficult to deliver. So over the course of the last couple of years though, so firstly we've had the building programme, so we've built those 3 new wards that replaced the 2 old surgical wards. So the bed capacity, if we can get the flow right, if we can get discharge right, which is a slightly different issue, but the bed capacity broadly is about right now to deliver that. And then we've just agreed a business plan, a business case a couple of last week or week before, which is going to build a new elective surgical hub on the Hereford Hospital site, which is another 3 theatres. So that puts the theatre capacity right, and that should be open if it gets national approval, and we expect that it will. That should be open by May 24. So that means we should have the beds and the theatres to get rid of those waits over time, and it won't happen. So that's some good strategic capacity views, and then in terms of the national targets for reduction of waiting times, we should deliver that. Potentially, junior doctor strike, as people will know, starts today. I mean, there is going to be some impact, and if we see that ramping up, then that may well impact on that. But we will meet the national target of 78 weeks by the end of March. And then the target for next year is nobody waiting over 65 weeks. So really, it's going to take another couple of years to get back down to nobody waiting over a year, where we were a decade ago. It was nobody waiting over 18 weeks. So we've got a long way to get back to where we were. But a number of things that are going well, both sort of tactically and strategically in terms of capacity.
Thank you. It's frightening being on that list, isn't it?
Yeah, indeed.
Thank you. Jane. Matt, did you want to comment?
Yeah, I just wanted to add, I mean, people will always need the NHS, won't they? And it's really important, but I guess what we want this strategy to focus is about preventive aspects. We talked about people to self-care, and actually if we get that right and the upstream stuff right, we can essentially reduce demand, and we've been talking about that for years, haven't we? But I guess it's that social movement we kind of want to inflict so people can better self-manage. And Gillian and her team did some great work around that as well, and how we utilise social prescribing and the community assets. So I think there's a real opportunity there. So people will always need NHS, and it is really at the forefront of people's mind, but just really trying to focus that upstream work that we know that makes such a really big difference.
Thank you. Any other comments or questions?
Last one, which is just real support for this. I think it's been a great piece of work. Actually, the engagement has been probably second to none. It's been absolutely brilliant. Really supportive of the approach to take a small number of priorities and really focus on them, bearing in mind that how we deliver those is across a broader range of things, as we mentioned, but to take a smaller number of things and us to really focus on that's important. And the other thing to say is having a governance approach where we are holding ourselves to account. What we don't want to do is sit here in 5 years' time like we did last year and say, well, that was a strategy, but really nothing very much happened. We want to sit here in 2 years, in 5 years, in 10 years and say, we've really made a difference to people's lives, and the governance is really important on that. So really supportive.
Thank you, Jane. I think we need to consider the health and well-being side of this strategy and acknowledge, like we've already discussed, the implication of housing, environment, and employment on people's lives. So that again is weaved through this strategy. And I thank you both for your hard work on it. Okay, so the suggested recommendation is that the board consider the report and notice progress, and the board considers its response to the draft and suggests changes for consideration as appropriate. Do we have any further recommendations to add?
I picked up that the language of secondary priorities, that they sound like second best priorities, and then there's some suggestion of whether we can change the language so we can ensure what is exactly meant by the goals in relation to priorities and principles. So that needs to maybe be a reflection and unpicking of the language, and that they can then help to deliver the core priorities. And then just finally, in addition to that, that there is that wider emphasis on health and well-being, such as housing,
Environment and employment.
Yeah.
Yeah. Are you content with that, Matt?
Yeah, that's fine, and we've had similar feedback from other partnerships, and we'll bring all that feedback back when we sign this up, so you can see how they're reflected in the revised version.
You've got a quick turnaround, haven't you, because you bring it back at the end of April, I think it is, so we look forward to that. So, can I have a proposer and a seconder? Thanks, Christine. A seconder, thank you, Hilary. So, what I would like to say are board members content to note the recommendations? Yeah.
Yep.
All in agreement, thank you. Thank you very much. Okay, let's move on to item number 8, and it's the thematic review of premature deaths. We have in the room Ivan Powell, who's the chair of the Herefordshire Safeguarding Adults Board, and Anne Bonney, who's the Partnership Officer for Children and Young People. Hope I've got the titles right. And I'll hand over to you, Ivan.
Thanks, Councillor. Is that on? Yeah. Just before I go into this, can I just check one thing out? In preparing for this presentation, we understood this was going to be a workshop and not a public meeting. There's no issue with it being a public meeting. However, embedded in the presentation are some videos of a family member who was involved in the review. She is very happy for her videos to be shown within professional discussions and professional development sessions, but of course has asked for her own reasons it doesn't go into the public domain. So is it possible to pause the public feed to play the videos or not? Because if not, we'll just skip over them. I'm not sure what the...
we should be able to do both.
Okay,
Yeah.
right, thanks very much. So
Yeah,
just to
I'm
clarify.
sorry about that.
No, not at all, no. And just to be absolutely clear, as it is a public meeting, this is not to not be open about any information. It is that it's very personal to the individual who's speaking, and it's a matter of respect for her and her family members. So that's the particular issue. They're only very short, but they are important to think. So I think I pretty well know everybody in the room, but I am Ivan Powell. I'm the independent chair of Herefordshire Safeguarding Adult Board, and that's important for a particular reason. So the Safeguarding Adult Board is about a group of agencies coming together to make sure that those adults with care and support needs who are at risk of abuse and neglect and are unable to protect themselves are appropriately supported. And that is important because one of the recommendations from the review was to have a conversation with the Health and Wellbeing Board about where governance of all of the supporting and enabling bits of the system sit. And I'm not sure actually how this conversation will chime with the discussion you've just had about your priorities, but nonetheless, it was a recommendation from the review. Having said that, the focus of the Safeguarding Adult Board is about adults with care and support needs. All agencies, including everybody in this room, have a prevention duty under Section 2 of the Care Act. So there is that broader conversation that needs to be had. So this particular thematic review considered the deaths of 6 individuals who had died in Herefordshire between January 2019 and August 2022. And the review was jointly commissioned between Herefordshire Safeguarding Adult Board and Herefordshire Council. Sorry, I wasn't sure which screen I was looking at, my apologies. So the review focused on 6 individuals, 5 men and 1 woman, and they died. The reason it was called premature deaths is the ages of the people involved. They were all adults, but they died between the ages of 24 and 54 years of age. And since the review has been published, there have also been a number of additional deaths in largely speaking similar circumstances for people with similar needs. Thanks, Anne. Before we conducted this review, people would often refer to vulnerable adults. Vulnerable adults was a particular term that was introduced into the system following the publication of a document called No Secrets. And that followed the publication, for those of you who remember it, followed the Panorama programme into a care setting called Winterbourne View, where adults were being criminally abused and assaulted by those who worked there, a matter of public record. The term vulnerable adults was wholly repealed by the Care Act. So there are bits of the system which have wrestled with what do we do with particular individuals who do not have care and support needs, but clearly do have some vulnerabilities. So what this review played out was the recognition of the people who we are now calling having multiple and complex vulnerabilities. And there were some overlaps in the review. Criminal justice, so all 6 individuals had contact with the criminal justice system, either as perpetrators or victims of crime, and in some cases both, with particular regard to domestic abuse. 5 individuals had been recognised as being victims of assault, and 2 of them had perpetrated violence. In terms of their physical health presentation, 4 of the individuals had been diagnosed with hepatitis C. 3 individuals had experienced falls on multiple occasions. In 2 instances, there was specific reference to head injury, and there was 1 individual who had fits which led to cognitive damage. Mental health was a considerable factor. All 6 individuals used substances. All 6 had experienced homelessness at some period in their lives, although they were not homeless at the time of their deaths. And in terms of that, the care and support needs, 2 had been formally assessed as meeting the eligibility criteria and were being supported by packages of care, the other 4 not. The review also explored adverse childhood experiences, clearly identified in 4 of the individuals, but arguably you could see evidence of 6. And I know the Director of Children's Services is on this call. In particular, 4 individuals had lost contact with their children as a consequence of the course that their life had taken.
So are we streaming?
We're live now again, Madam Chair.
Thank you very much. Sorry about that little difficulty we had with the technology, but hopefully now we're all back in the room and we'll continue.
Okay, thanks, Chair. Appreciate some who aren't in the room couldn't hear that conversation, so apologies for that. Technology has thwarted us today. But it's important that when we think about our discussions at a strategic level in the system, that our discussions remember at the end of this that there are individuals and families who are directly affected by the conversations that we have at this kind of level. So what the review found at this particular time, and you know, some of this is some of these things are the system things we are still wrestling with. At that particular time, no apparent coordinated response to frequent attendance at accident and emergency. No apparent approach, or no apparent change of approach to repeated did not attend. So in a number of bits of the system, there was a tendency where individuals had not turned out for a particular number of appointments, usually 3, then the case got closed. It was felt there was insufficient outreach across the system and in reach to facilitate engagement regarding the completion of assessments and work plans. At that time, very few multi-agency meetings and no apparent pathway into meetings where there was a significant risk of harm. Thanks, Anne. Moving forward, the Safeguarding Adults Board have introduced what's known as the Complex Adult Risk Management Pathway. Ewan will speak after about something that was called Project Brave. There are some next steps and thoughts about that. And one of the questions posed is the system, does it now have an embedded approach to coordinated assessment and delivery of interventions, and particularly with the appointment of a lead agency? So my answer to that question is we've made some progress, but it isn't consistent across the system. Thanks, Anne. Some reflections from the review was the system undertaking care and support assessments or safeguarding approaches consistently all of the time? Were Mandy Appleby be here, she will say that is not all of the answer, but it is an issue which needs some further thought. Certainly drug and or alcohol abuse was seen as a lifestyle choice in some cases, rather than being viewed as people making unwise decisions and being deserving of support to help challenge those unwise decisions. There were not consistent considerations all of the time of whether a person had mental capacity, and I'm sure I don't need to remind anybody in this room, mental capacity being time and decision specific. And in the cases of individuals involved in this review, of course, fluctuate, because at a moment in time, somebody substantially under the influence of alcohol and or drugs may not have capacity, and of course that will change very shortly after. There was a lack of sufficient provision of wraparound support. And actually our experience in the Safeguarding Board and through Project Brave is that wraparound support is actually not very difficult to deliver. It's almost, on most occasions, forgive the expression, but supporting somebody, hand-holding them almost, just to navigate what can sometimes be a tricky system. And particularly if you're somebody who might not have a mobile phone, for example, if you haven't got a home, it can be difficult to access services. A need to recognise trauma informed and adverse childhood experience. The Safeguarding Adult Board, or sorry, that's not accurate. The local authority secured some money from the Department of Levelling Up to deliver trauma-informed training across the workforce. So 200 and odd people were trained. There was more capacity than that, but I think we were in a difficult position at that moment in time with the pandemic, and we probably didn't maximise that opportunity. And a need to focus on the background of individuals. So if you hear Michael Preston Shute talk, who's an academic in adult safeguarding, he will talk about getting alongside and understanding the person's story so that you can start to take some steps forward with them. Next slide, please, Anne. Some of the challenges regarding mental health and substance misuse. What provision is available, including assertive outreach for those with mental health challenges, but perhaps do not reach the threshold of enduring mental illness? What can we reasonably expect of general practice in monitoring and responding to individuals' mental distress? All six cases involved substance use, and there was a question about whether non-substance misuse specialists were routinely considering those particular issues and discussing those with those that they were supporting. Joint working when there are multiple and complex needs was a particular issue. We do have in Herefordshire a dual diagnosis pathway. Turning Point, the drugs and alcohol treatment provider, will say it's better in their experience than some other areas that they work, but it remains difficult on occasions. Thanks, Anne. Just flip on, please. Just to pick out a couple of things there. Is there a system change required to help individuals who leave treatment with, leave hospital with incomplete treatment? And there was a question about what positive difference a super surgery is making. I think it's just appropriate to reflect here that we were delivering against some of the findings of this thematic review through the piece of work that became known as Project Brave. And absolutely understandably, because we were in the middle of the pandemic, health providers couldn't get alongside and as close to this as ordinarily we might have liked. And that's no criticism, it is a reflection of the difficulties of dealing with the pandemic. I think the questions like, what can we reasonably expect of our GPs, about leaving hospital with incomplete treatment, those are the kinds of things which we feel are still the legacy issues we've not quite nailed in terms of the response. Flick on, please, Anne, just go to the recommendations if you would. So the recommendations that came out of the review, some very practical ones there. The overarching recommendation, which is why I've come to talk to this board, is the group of individuals involved, some would be, in inverted commas, under the governance of the Safeguarding Adult Board, in that they would have care and support needs, but in truth, the majority not. You and Archibald did some work across Herefordshire, and at a particular moment in time, we think there are 156 individuals that we could say right now are in that group with multiple and complex needs. And so those are those who are in and out of accident and emergency, in and out of mental health crisis. They're having a focus within the police on what they call their problem-solving approach. And of course, all of these circles are concentric, and some of them overlap in ones and twos, some of them overlap entirely. Before I go on to, I was going to, there is one last word for Amy, but given the IT is not working, I don't think it's practical to use that now. And I think I need now to hand over to you and to follow on to discussion. Is that right, Hilary, do we think? But that would be better rather than having a pause for some discussion now. What would you rather do?
Should we do a pause for?
Okay.
And take any questions?
So sorry, if I can just explain that. So Ewan is going to talk about some of the next steps, particularly from the local authority perspective, albeit it is multi-agency in nature. There are still some issues, I think, which remain unresolved from a Safeguarding Board perspective. Christine, please.
Yeah, I just had a question about the recommendation 11.1.3, which is around the leadership and the different boards. And I wondered whether you had a view on how that's best achieved.
Largely speaking, it's why I'm here, really. So the Safeguarding Adult Board, in conjunction with the local authority, commissioned the review. So therefore, as the board, as the co-commissioner of the review, in effect owns the recommendations and the action plan. So that means we have a governance responsibility to make it land effectively. The Safeguarding Board itself hasn't got such a direct line of influence, particularly some of those things, hospital discharge, for example, mental capacity, the legal literacy and understanding of all of our staff, all of the workforce, those kinds of issues, the Safeguarding Board can only go to areas and seek assurance from. So that, hence being here, there is a need to have a discussion about does governance overarching governance sit with the Health and Wellbeing Board, and the Safeguarding Board supports some elements of that. So it's been a bit of a catch-22 discussion, to be frank.
So do you think there's a recommendation there, Christine, that you want to add?
I'm not sure what the recommendation needs to be, but you've got quite a few places listed in that recommendation around where we're working with complex vulnerabilities. And unless we narrow it down to know exactly where we could be assured that that work is coordinated across all partners. And I'm just kind of wondering what about Project Brave on the agenda, is that the right place or not? Is that something that could report to the Health and Wellbeing Board? I don't know.
Yeah, I think Matt would like to come in now.
Yeah, I think that's a conversation we need to be I mean, it's like multiple long-term conditions, isn't it? We often treat things in disease silos. It's, it's how to eat an elephant, not the best expression, but It's back to that governance conversation. I think Project Brave would be interested in you in terms of what the plans are for that board to oversee that work, and that might be where it sits, but recognising again that actually there'll be loads of deliverables across other partnerships. We have a local substance misuse partnership, there's a county drugs partnership, there's mental health collaboratives we've already talked about, so it's kind of knitting it together, but somebody has to hold it, like you say, it's back to your previous conversation, isn't it, Christine? So maybe Ewan might put Ewan on the spot, but I think we can work that through probably as we write the strategy as well, because we've got complex vulnerabilities as a supporting priority, as I think we're now going to be terming them. So I think we can work through that.
Thank you. Thanks, Matt. Councillor Toynbee.
Yeah, thanks. It's really helpful. Reviews are very helpful, aren't they? And case studies, it really helps us, understand the issues. Yeah, I'm sure that the answer to this is it depends on the person and the situation, but who's responsible for following up on non-attendance? Because that seems to be quite a big problem.
Okay, so this probably isn't best aimed at me, but the role of the safeguarding board is to seek assurance from the agencies about what they do about either did not attend or was not brought, because of course some people need to be supported. So I don't know across the health system where did not attend, was not brought currently sits.
Do you want to comment, Jane?
I mean, it's a complex area, isn't it? I don't know the answer to that question. Saying there's the policies in place that people who constantly don't attend don't keep giving appointments and waste capacity. We've got some very long waiting lists. So, but obviously there's a different approach for people, and I'm interesting. I think, Ivan, when you say, this is about 150 people, this isn't a very large cohort of people. I mean, probably we need to hear from Ewan about Project Brave, but it seems to me we've got a safeguarding adult board in place, and these are people with complex vulnerabilities. So it seems if it is unable to do its job properly because it hasn't got the right people or hasn't got the authority, then it seems to me we need to fix that rather than put something else in over and above it. But maybe we'll come back to that at the end.
Ewan's on the.
Ewan.
Thank you, Chair, and thank you, Ivan. Just on this issue of non-attendance, I think what the deaths review has looked at in detail and what Project Brave to some extent is also emphasising and taking forward is a new way of, or a more assertive way of looking at non-engagement. Non-engagement or disengagement by vulnerable people from a whole range of services and forms of support is a critical risk factor in preventing deaths, and it's also critical in the wider work of supporting people on their journey through homelessness and complex vulnerability. And over the last sort of 3 years during Project Brave and from the beginning of COVID, we've been working with a variety of agencies who directly support people, whether that's in housing or substance use or wherever, and the voluntary sector in particular, to have a different appreciation of non-engagement and to be less willing to accept, the non-engagement or not turning up to things, or people apparently being fine but choosing not to engage with things. It is not a straightforward thing, and we have to be very mindful of people's right to make decisions, wise or unwise, and that people will often present as being okay when they're not. But I think we have succeeded over recent times in a range of services and teams of people having a more evolved understanding of this issue of engagement and being willing and able to seek multiple ways and different ways of communicating with people and ensuring that people get access to support even if they won't engage with a particular attendance or a particular consultation or activity. More widely in relation to multiple complex vulnerability, as Ivan has said, we've identified very easily by just counting people known to key agencies around 150 people. I'd be confident that's more like 200 if you particularly account for, sadly, the people who have died and also those under 18. So when we last looked at this, we identified at least 25 to 30 young people, 16, 17, who would meet this profile, but we were at that point focusing on adults. So it's around 200 and potentially
more, but these people are generally readily identifiable by services because of the nature of their journey and the complexity of their needs. The key thing to point out is that, and we'll cover this a bit more in the Brave presentation, but the council and its partners have been very successful in attracting funding to the homelessness dimension of Project Brave, but it has proved a lot harder to attract external and government funding to the wider work around complex vulnerability where it doesn't specifically involve homelessness. And whereas Herefordshire has got probably more of its share of the pot nationally around homelessness, it's struggled to attract the funding available for the wider vulnerability, and that's something that we need to reflect upon. Thank you.
Thank you, Ewan. Did you want to add something?
Just a really quick point, if I could. So, as part of sharing the learning from the review, we had a workshop which included managers and practitioners. So, just use this example, and if it's the wrong expression, forgive me, but the liver specialist nurse from Wye Valley Trust was present and explained her frustration that they'd supported an individual through treatment and detoxification, and knew that on discharge there was a risk that they were going to return to homelessness, and they were really carefully looking round about who they could put that individual in touch with, so that they were supported on leaving treatment, if you like, discharge from hospital. And of course, unfortunately, that wasn't available. Back to that point about assertive outreach, and Ewan is right. Third and community sector have a huge role to play in this, and have done so. But because that individual didn't have that support, they very quickly returned to use of alcohol, and of course, all of the good work that had been conducted in the trust was very rapidly undone. So I wouldn't want anybody to think that there is not thoughtful and careful practice going on. It is a fact that at points at a moment in time, one bit of the system stops, and if there is not another bit of the system to pick somebody up, then very often that's where it can fall over. So I wouldn't want people to be thinking that all professionals were kind of being dismissive. That isn't the case. It is problematic. Hence the complex adult risk matrix process.
Yeah, thanks, Ivan. Well, first of all, I'd like to thank Amy for her, coming to have that interview or session with you, because, what an emotional, powerful meeting that was. And I think that it will be available for people who didn't hear it properly on the slides, etc., that we send out to the board members. I can't believe it's a year since Professor Preston Shute brought us this review. I remember it really quite vividly, and it's a harrowing thing, really, isn't it? And I was disappointed when he said that further premature deaths have been identified in this last 12 months, which is sad that we're not actually crossing every avenue that we can. Okay, so Councillor Hitchener.
Yeah, just to your point there, Chair, about other deaths having occurred. Do we have a record of those? Do we know how many there've been? How big a problem is it continuing to be?
Yes, we would have a record. Ivan, do you want to add to that?
Sure, thanks, Chair. Thanks, Leader. I won't know the exact numbers, but Ewan may do. But we are continuing to talk to the coroner about their view on some of these cases. If any of the cases met the criteria for a further safeguarding adult review, then obviously that would come to the Safeguarding Adults Board. To my knowledge, I have received 5 further referrals for a safeguarding adult review where people have died, and they've not met the criteria for that review because the individuals didn't have care and support needs. However, the Safeguarding Adult Board has learned from the world of children, and it undertakes what we term an adults rapid review. So we do identify some learning from those cases, even though they don't go to formal review, and that feeds back into the system. But you won't be surprised to know, I'm sure, that the learning kind of reinforces what we've learned from this particular thematic review. And Ewan Chair has got his hand up again.
Thank you, Ivan. Ewan?
Thank you. I'm no longer, my role no longer monitoring the deaths as they come in, but I understand that it's been suggested that over the winter months, this winter, up to 4 deaths have been identified as possibly falling into the same category. But I can't confirm or verify that number. The cut-off date for cases to be included in this review that Ivan is reporting on was August 2020. I do know that during the period of another 18 months or so to take us to the sort of early spring of 22, there continued to be a significant number of deaths, particularly in the latter part of 2020 and through much of 2021. My understanding is that the apparent rate of deaths, or frequency of deaths rather, has been lower, particularly during 2022. But I'm afraid no longer see all the detailed figures, so can't confirm that for certain. What I would say is that during that whole period, some of the deaths that have been recorded and identified for learning would be classed as relating to people of multiple complex vulnerabilities. Some, however, would be more narrowly defined as drug-related deaths, without necessarily the more complex kind of background and morbidity involved. And I think that the issue of drug-related deaths is something that the DPH and other colleagues, as part of the system, the ICB system, will be looking at the methodology we use for monitoring and responding to drug-related deaths more generally.
Thank you, Ewan. As always, very thoughtful points there. Okay, so I think before we move on to the next agenda item, I'd just like to cover this one off, if that's okay with everybody. If we've got any more comments or questions, can we raise them now? Yeah.
Thanks. I might just come back to my previous point, really. I mean, it's the and so what are we going to do differently? It sounds like, I think what you're saying, Ian, there's been quite a lot that's been done through Project Brave and the pathways. I think you're saying that but it feels like there is more that we can sensibly do. So say I'm sort of torn because it feels a bit like, can we make this somebody else's responsibility to be responsible for it? But actually, do we make it be clear that this is the responsibility of the Safeguarding Adult Board, and that so for example, some of the things around following up did not attend or so forth, that there's some clear recommendations that come to GPs or for the services that we provide around actually we think this is the right way to deal with this, and then we've got a place to put it in. But it feels to me that the board is the right place to hold us all to account for that and to come up with those solutions with some of the workshops that you've had, rather than saying it's got to be someone's higher responsibility. My worry is we dilute it rather than give you the authority that you need. So I guess that's what I'd be interested in. How do we fix some of the holes that are still in there and make sure that we've got the right level of accountability across agencies to do that?
So the recommendation was for the Safeguarding Board to have a conversation with the Health and Wellbeing Board about where governance sits. I'm the outgoing independent chair. My tenure concludes at the end of March. There'll be a new chair. We've just had, as a Safeguarding Adult Board, a development session with a view to identifying the strategic priorities for 23-26. So I guess that means me going back to the Safeguarding Board through the new chair to say the Health and Wellbeing Board's feedback is we support governance being at the Safeguarding Adult Board and make it happen, I guess. And
what do you need?
Yeah.
What do you need differently from agencies so that we can make sure that you've got everything you need to make it happen?
So some of that will, I've got no doubt, come out in Ewan's presentation. But I guess the takeaway from this meeting, which is helpful, is Health and Wellbeing Board are saying to Safeguarding Adult Board, just governance sits with you, please. and come, there will be the odd issue, I suspect, where the safeguarding board will come back and say, well, actually, that's beyond our sphere of influence.
Yeah, and the other thing I guess that's important to that is where do you go back? So for example, if it's that we haven't sorted out the way that we differentiate DNA policy for people who are vulnerable and people who aren't, then it's something that needs to come directly back to me. It doesn't have to come to health and wellbeing. So there's about direct engagement back to organisations as well that I think would be incredibly helpful.
Okay, fine, thank you.
So did you get a recommendation from that, please,
Yes,
Henry?
the recommendation that governance should ultimately sit with the safeguarding adult board.
Yep.
Yeah. So can I have a proposer for that? Additional recommendation? Thanks, Shane, and a seconder. Thank you, David. Okay.
Sorry, I think there's a second part to that recommendation as well, isn't there? And for the board to explicitly say what it needs, if it hasn't got what it needs already.
Yeah, for sure.
Identifying the needs to facilitate that. Yeah. Okay. Well, actually, before we move on to Ewan, I want to say something to you, Ivan. Momentous moment, isn't it? For probably the wrong reasons. As you did mention, you are going from your role at the end of March, and you will be really missed. I'm telling you that now. And you're stepping down. Hopefully, doesn't mean that you're going to be out of the system, but it's not, because I hear that you're going to still be doing some safeguarding work, hopefully for Herefordshire as well as anybody else. But I wish you well in whatever you're going to do, and no doubt we will see you in the future. Please stay in touch, and thank you very much for your services. Oh dear. Right, okay, let's move on. We'll go to Ewan now and the Project Brave, which is the next item agenda. Actually, no, we need to sign that one off. So is everybody in agreement that we take this report as presented? Yeah, thank you, thanks. Okay, Ewan, so we are looking at Project Brave strategic approach.
Yes, I'm sorry.
Still here? No, it's fine. Just checking on my screen rather than twisting my neck, but thank you, Ewan.
Thank you, Chair. I'm hoping that John Coleman is going to help me by driving the slides today. Looks like he is. Brilliant. Thank you. So yes, here today to talk about the strategic approach to Project Brave. You will appreciate, many will know that Project Brave is something that emerged rapidly during the COVID pandemic emergency. It was exactly 3 years ago in the spring, in March of 2020, and so it emerged in a very rapid and pragmatic way, with the local authority and various key partners working together to do what was needed to protect vulnerable people, including those who are homeless, and therefore it emerged organically over a period. And so we are taking the opportunity some time on to reflect on where it has got to and what its priorities and focus should be going forward. So hence we are now proposing this strategic approach to Project Brave. This proposal has gone to Cabinet and been approved by Cabinet in February this year, along with a review of the progress against the Council's homelessness prevention and rough sleeping strategy, which is the wider strategic context of this work, although as you will see, Project Brave is rather broader than homelessness. So from the very outset, this slide's a bit busy, but it gives you an idea of the breadth and scope of Project Brave, and we'll go into some more detail as we go through the slides of the various elements summarised here. Project Brave was always, from its inception in the spring of 2020, always about both homelessness and wider vulnerability. It was always focused on people whose needs might in many cases be complex and who were significantly vulnerable, but for one reason or another were unlikely to be best served by statutory and core services, either because their needs sort of fell between stools in terms of eligibility, or because of the issue of engagement with services, which we already mentioned, and very often a combination of those two factors. In practice, particularly during 2020 and much of 21, the detailed application of Project Brave was focused on homelessness because of the statutory drivers that were there for that, and because of, to some extent, the funding that was available. There has been an attempt since then to direct more energy and impact to the wider multiple complex vulnerability side of Brave, even where the individuals are not particularly challenged by homelessness. As we've said, that has been challenging partly because of the availability of funding. So this, among other things, this strategic approach re-emphasises the twin elements of Project Brave. If we can go to the next slide, please. So this, in summary, it is about changing lives for people, or enabling people to change their own lives and make their own decisions on the journey that they're on, to become more independent and to live safe and fulfilling lives. A key element of this is to find real homes for people who have otherwise been homeless, and to find solutions for people that include a safe and comfortable home of their own that they can stay in for the long term. The breadth of multiple vulnerability is spelled out here. So we're defining complex multiple vulnerability as people having significant experience of 3 or more of these 5 areas here. And the 150 people we mentioned earlier, or possibly 200, it's very easy to identify people with that, unfortunately, people with that level of complexity. And a growing focus, a new element of Project Brave, which wasn't the focus in the first instance, but now is increasingly the focus, is around working more preventatively to prevent people, so far as possible, acquiring this level of complex vulnerability. And so we'll be doing that in conjunction with Talk Community and with partners across the system. Next slide, please. So the overall aims of Project Brave, they are, as you can see, very broad, and they're recognising the impact for individuals, but also potentially the system. Homelessness obviously is front and centre, but not the only story here. One of the things that emerged from, within a few weeks really of the development of Project Brave was the idea that we were onto something here in the way that we were working through the Everyone In initiative, and there was partners began to genuinely believe that there was a way of trying to eradicate at least high-risk homelessness from Herefordshire altogether. And we've made significant strides in that direction, but it has been challenged by what's going on more widely nationally in terms of social policy and social pressures on vulnerable people and families. But you'll see the breadth is very wide here and encompasses a whole range of different considerations for system as well as individual. And I would draw attention to the last point here, which is there is a key element of this, which is about finding real homes for people to live in. And in order to do that, we need to draw on a range of accommodation and property and capital funding assets across the system. It can't be just the council that does that. We work with our housing partners who own a lot of accommodation. We find ways of incentivising and working with private landlords, and we draw on all the funding opportunities that are available from government and elsewhere. Thank you. Next slide, please. So as I say, as part of bringing forward, at the same time as bringing forward this strategic approach to Project Brave, we were at the midterm point, more or less, of the council's homelessness prevention and rough sleeping strategy, which is a statutory document. When this was written and signed off, it was largely written in 1919 and only formally signed off in 2020, Project Brave had not happened. And so some of the opportunity and some of the resource and some of the energy that Project Brave has brought was not anticipated by the strategy. What that means is that some elements of the strategy have gone considerably further or been implemented to a greater degree than was envisaged at the time the strategy was written. Other areas, less so, particularly those that involved structural activity or working in a particular way with partners and with the public, couldn't really progress during COVID. And so there was some delay in those, but all of those now are receiving attention and will be caught up with as part of the, within the period of the implementation of the strategy. But significant areas have advanced further than envisaged because of Project Brave. Also a key element which has been introduced in the last few months and will help drive and frame the approach to Project Brave and contribute to the homelessness prevention strategy is MEME, and we'll talk about that a bit more shortly. Next slide, please. So MEME stands for Making Every Adult Matter. It is something initially instigated by government, but taken forward as a national programme by Homeless Link, which is a voluntary organisation, but one which is, is heavily sponsored and heavily associated with government, and often leads its policy initiatives, particularly obviously around homelessness. So MEME is something that's been operating nationally for some years. It is not a funding stream, but it is a national network for best practice, for training, mentoring, sharing of resources and intelligence. The Herefordshire Council and its partners sought membership of the MEME network, which is quite a formal process, requiring satisfying a number of criteria and going through quite an exhaustive process. During the middle of last year and in September, Herefordshire was successful in being welcomed into the MEME network. So this will bring considerable focus and support for us working locally across our partnership. It's already given a kind of boost and a further emphasis to the partnership working aspects of Brave in particular. The scope and approach of MEME aligns very well indeed with Brave, and in fact, you would almost think that Brave was a kind of model approach to it in many ways. One of the specific aspects of MEME, which is interesting and in a way challenging for us locally at the moment, is that it assumes that you're starting from nothing, that this is an entirely new approach, and that you therefore need to work in a particular way, including with very small groups of people on a sort of pilot basis. And use a sort of focus group approach almost in order to build up your evidence of how you're working. So whilst we are seeking to do that, it's challenging, of course, because Brave has already been existing for several years, is already working on a larger scale than that, and has done some of the things that MEME seeks to develop some time ago, but has not done some of the other aspects. So we're working with Homeless Link and other partners on exactly how to make that work in Herefordshire, and particularly in terms of identifying a key group. And we'll be focusing on a group for whom so far the Project Brave initiative has not had the same impact for them as it has for many people. There is within MEME a particular focus on homelessness, but it does embrace the wider multiple complex vulnerability agenda, as does Brave. Next slide, please. So this just is a slide to illustrate the alignment. On the left, you have the core, the objectives of MEME, 7 of them that we have to sign up to, and which are the core of the MEME approach. And on the right, what already exists in Project Brave, which is a way of mirroring or reflecting the requirements of MEME. So it just underlines the alignment and the compatibility of our Project Brave with the wider national MEME approach. And one thing to identify here is the second line down, knowing who everyone is. So one thing we realized quite quickly with Project Brave was that finding people for whom this was appropriate was not really a problem. And indeed, this, as Project Brave has developed, of course, it's not a service so much as a group of services and an approach and a network of provision and models of approaches. It's not about referring into Project Brave. It's about if you are known to any of the services and partners engaged with Brave, and you meet the kind of criteria for vulnerability and risk, then you are part of Project Brave. So there isn't a referral system as such. And interestingly, if we look back over previous years prior to COVID, there were 1 or 2 attempts to do elements of what is now Project Brave through other projects in Herefordshire. And a couple of those in particular, I think, were seen to fail. And one of the reasons they failed was that they were referral based and the referrals didn't come through. So all the agencies could identify and talk about the needs that were out there, but when it came to actually referring individuals into a specific service to do a specific thing, it didn't work. And I think that was partly because of the diversity and complexity of the user group. Next slide, please. The key element, as I've emphasised already, is homes for homeless people. And so a key priority early in the development of Brave was a focus on actual bricks and mortar and actual homes that people could move into, and not just temporary accommodation under the Housing Act and Homelessness Reduction Act, which is a very limited statutory. They're moving beyond that and recognising that there were two types of accommodation that we needed on a much larger scale. One was, long-term homes that people could live in for years, even if they needed support in order to manage their responsibilities as tenants, but also, and for some people before they could move into that accommodation, transitional accommodation, so that where they will get support, that support will vary according to need and will taper off potentially over time, and from which people will move on. And we've got different types of accommodation with different move on trajectories, but usually the maximum period in transitional accommodation is up to 2 years. And that's reflected in various national funding streams. These numbers actually come from a little while ago and they've slightly changed. So in fact, we've got slightly fewer long-term units already secured, but others in the pipeline. And some of about 6 of those units that are identified as long-term have in practice become transitional accommodation because of the nature of them more suited to that. Some of the units at Hope Scott House already existed but were not available for management in terms of transition, and were kind of separated from the rest of the system. The White Cross Hub is a new development during the period, as is Headley Lodge, where we're partnering with the Abbey at Belmont, and particularly want to draw attention to Blackfriars Street, where we've converted so many derelict buildings that the council owned into 6 high-quality flats for people living more independently. And similarly, we've acquired 6 new units of housing, self-contained one-bedroom houses around the Hereford city. And to both of those schemes, people are being supported on a sort of floating or outreach basis. And there is a continuing pipeline of accommodation, both transitional and particularly long-term. Thank you. Did you miss a slide there, John? Yeah, so we talked a lot about multiple complex vulnerability. I'm not going to go on about it, but this is the breadth of what we're talking about and some of the focus within Project Brave. And we have, although resourcing has been difficult, as I've said, there have been some key pieces of work that are very valuable, particularly involving Wye Valley Trust as well as Mental Health Trust and other partners. So there is a well-established project around mental health. So people with multiple complex vulnerability, where their main primary need is mental health, and where they are very high intensity users of blue light services and A&E. So there's a well-established project now that works on the multidisciplinary model. It's based around the A&E kind of demand, and identifying key cohorts of people and finding different ways to work with people. That's been an excellent project with really good engagement from all partners, and is showing real benefit for individuals. There's also, loosely linked to Project Brave, there's a high-risk alcohol multidisciplinary pathway for people, particularly who are treatment-resistant drinkers, a very significant clinical risk as a result. Again, focused on demand showing itself to Wye Valley, partly through A&E. There's obviously the ongoing work around reducing deaths, not least, as I mentioned, in relation to substance-related deaths, even where people's needs are less complex, and that work includes police, public health, and other NHS colleagues. There was some very good work done around Project Brave, particularly during the middle of 2021 and then in 22 around vaccination, particularly for obviously COVID, but then to some extent around flu. Very difficult user group with which to work in relation to this, but some excellent work done. And although lower rates of vaccination achieved than for the wider population, significant increase on the previous access to primary care generally and to vaccination for that user group. Access to primary care is obviously a very critical issue for this user group. And progress has been made over the last 3 years, particularly with the proportion of people registered with a GP. There's still got a lot of work to do around joined up working between primary care and other areas, other professional areas, and particularly managing risk around substance use or prescribed substances for people and the link to mental health and wider need. And as Ivan has already said, there is an appreciation of the enormous pressures on primary care, make it difficult for them to devote all the resource that might ideally be beneficial to this area. But there's a desire to continue working across the system with primary care and other NHS colleagues on this area. And of course, NEAM will help us not least with access to wider research and evidence-based material around complex vulnerability. Next slide, please. So over the last few months, there has been increasing focus on what can we do to be more upstream. As it began and as it has been for most of its time, Project Brave has not been a preventative project. It's been about rescuing people. It's been about people that, amongst the most vulnerable and at highest risk in our society, and finding solutions for them in terms of homes and health and reducing immediate harm to them. However, of course, the more work you do of that kind, the more you focus on how you might prevent that level of need. So there is now a very serious discussion going on about how we work, particularly through Talk Community and in wider partnerships around upstream prevention. And although this has various elements, and there are particular opportunities to identify risks of homelessness and how we prevent that more upstream, and there is a good prospect of making progress in that area. The more challenging area is that if we look across the whole Brave cohort, the one factor, particularly around complex vulnerability, that is more prevalent even than homelessness is substance use. And preventing high-risk substance use and preventing deaths from substance use, as many are more expert than I will say, is a very long-term thing. And we do have a particular generation of people who are now in their mid-40s to mid-50s who have been taking, often a variety of substances for up to 20 years. And are now seeing the very serious impact of that on their physical and mental health. So prevention in that context is not a straightforward thing, and it is a very long-term consideration, but there is work going on across partners to look at the most effective interventions and approaches to prevention. At the moment, this is an area where we've not managed to attract particular funding, as we haven't have also attracted little funding, as I mentioned, around complex vulnerability. So that does inhibit us to some degree. Next slide, please. So Project Brave at its heart is about working with people as individuals, about listening to them and them deciding what their priorities and objectives are and how they engage with various forms of support. However, we took the opportunity at the back end of 2022 to do some formal structured engagement with a wide range of professional stakeholders and partners, but also with people with lived experience. These are some of the things that came out of that that engagement. There was a small group of about 7 or 8 people who lived experience. They were mainly people whose experience was homelessness. We're committing in the strategic approach to Project Brave to regular and ongoing work with a sort of ever-evolving focus group of people who have experience. We want to make sure that is broader and more representative of a wider range of need than homelessness. And we also want to work on how we identify and how we support people to participate in that work so it's meaningful and comfortable and safe for them to do so. But you'll see some of the themes here. And these some of the things have been directly tackled by Brave, but it just shows one way to go in being most effective. Mobility is a key issue here. So particularly people with long-term homelessness need will some will move around between Herefordshire and other areas. Another thing that emerged very strongly is that people are ready to seek help with a long-term need when they're ready. And that, if that's substance use or mental health need or some other aspect of their needs. And this goes back to the engagement issue. There are times when people, the sport's available to people, it would make them safer and change their opportunities, but they're not ready to engage with it. And then a few months later they are. So we need to make sure that services are sufficiently adaptable and flexible and sensitive to people's own priorities and sense of when they can seek and get help. Next slide, please. This is just some key metrics as we come to the close of the presentation, just to give you an idea of the scale. So more than 250 people, that's households, not individuals, accommodated at some point during Project Brave. Of those, 150 plus supported into long-term and transitional accommodation. From the original cohort of Project Brave during the pandemic, only 2 households remained in emergency or transitional accommodation beyond periods that were acceptable. Various people have moved out of or found their own solutions, as sometimes happened, or moved out of the area. At any given point, our homelessness rough sleeping outreach team, which is a team of 5 people, is working with between 85 and 105 people. It's at the moment in the 90s. The majority of those are not rough sleepers currently, and probably most of them will never have rough slept, but they're people considered to be at imminent risk of rough sleeping or other forms of high risk homelessness. What we're seeing at the moment is we've seen with the onset of the cost of living crisis, we're seeing a different profile of people who are high risk homeless coming forward, including a lot more family groups, unfortunately, with children, and also people who find themselves suddenly at risk. So we're seeing more people sleeping in cars, for example, as just one dimension of that. So 60 plus units of accommodation secured, with more in the pipeline. And the funding achievement is significant, as we've mentioned. So far, and we've got more revenue funding applications going in now to DLUC for the period to 25, but we've already secured 4.2 million in revenue and 800,000 in capital. The council also committed, in effect, £1 million of its own capital to acquisitions and housing projects in relation to Project Brave over that period. But just to underline, I'm sorry I've made this point a few times, all of that is basically about homelessness. We've not been successful in several applications that the council or its partners have made around wider vulnerability, and an area I would particularly draw attention to is around ex-offenders. The current offer, both around housing and around wider support for ex-offenders in Herefordshire, is not strong, and various attempts over recent years to improve and invest in that have not really progressed, particularly because of the difficulty in attracting funding. We've 3 times applied for set piece funding opportunities through government around ex-offenders in the last 2 years, and each time have basically been told we're not a priority area. And I think that is something to mention and to highlight. Next slide, please, which I think is not quite the final one. So we are focusing in the strategic approach on having real impact and making sure we can measure that impact. These are some of the key potential performance indicators. We're not potential now. We've got a dashboard that we're reviewing and I'm going to share with partners, and then we shall be able to crack on and start reporting on this dashboard fairly regularly. It'll include most of these elements and some others. We're conscious of the need to continue to demonstrate impact for individuals. Some of that can't be captured effectively by data, so we are looking partly through the work with people with lived experience at charting impact through stories, case studies, quotations, and so on. And so there'll be reporting that also captures that in relation to the impact for individuals. Next slide, which I think is the final slide. So this comes back to a question that was being asked around the deaths review. So the expectation, I think, from the beginning was that Brave would be seen as reporting through to the Health and Wellbeing Board, but also with periodical reporting to the Adult Safeguarding Board, and also with a strong dotted line to the CSP. And as Matt has already mentioned, there is quite a focus within Brave on substance use, among other things. And of course, there are lots of other joint and partnership arrangements that are also working on that. We want to be joined up and not tripping over each other. So there will be, needs to be some choreography to ensure that that works. The proposal which we're now implementing is to refresh the current internal project governance for Project Brave, which includes a multi-agency strategic or partnership group and 2 operational groups. We currently have one established one that mainly focuses on homelessness. We did have one for multiple complex vulnerability, which we're now going to refresh and relaunch. So we've already got project plans. We've had some PMO support, which is now tapering off, and so we can continue to report progress on Project Brave through Verto. Last point, which is there hasn't been particular interest in, but it's included on the slide here, was a consideration of whether we should change the name and the kind of branding of Brave. Some people don't like it, but that hasn't gained any traction. Interested in the views of board members in relation to that, but there is no immediate work being done around the change of name of Project Brave. That's it. Sorry, that was a bit lengthy, but obviously a lot of work to capture there. Very happy to take any questions that board members may have.
Thank you very much, Ewan. And I thank you for your comprehensive approach to this strategic targets that we need to look forward to. It's really important that we note the many, many personal experiences we've had at Herefordshire Council. We've had many people that we've helped come back to us and thank us, etc. But it's not all about receiving thanks, it's helping those people in most need. Any questions or comments from members, please?
Yeah, just one. Thanks, Ewan. That was brilliant. And although I've been sort of touch points with Project Brave over the last 3 years, it's the first time I've sort of heard it all together in one place, and it's such an impressive piece of work. So thank you for that. I guess there's 2 things really. My question is, I guess the first one is your last question. Do we call it Project Brave anymore? And I don't mind. I guess the word project is the one I'm worried about. Where's the ongoing funding to this, or does the national funding dry up and in 12 months' time we're not going to deliver this work anymore? So what does the future look like in terms of a business as usual approach, whether we call it Brave or something else?
Thank you. Yeah, I take your point about the word project, and that hasn't actually been the focus of discussion, but I take your point. I think it possibly should be, because it does imply that it's temporary and still emergent, and the whole point of the strategic approach is that we're now moving beyond that. So I think we shouldn't get hung up on the name, but I do think there should be some reflection on all aspects of its identity and how it's understood by people, particularly real people who are part of it, but also the professionals we're asking to engage with it. In terms of funding, so the core funding that's supporting the current work, which again is mainly focused on homelessness, is secure until April 25. We've now got opportunities to apply for funding, some of which overlaps that period, some of which goes potentially further. DLUHC, however, is prioritising, it is not continuing to fund in quite the broad way it has beyond 2025, and is now seeking to fund areas based on what it decides are our priority areas of need or deficit. For Herefordshire, they've decided that's accommodation and support for vulnerable young people, and we're very happy to be seeking funding to support further development in relation to that. There is some additional funding for the period 2025, which we can seek to apply for, and we are now. So for the moment, we're okay. I think the government's intention is to evolve the way it funds this work. I doubt it's going to stop funding it anytime soon, even around homelessness, but I do think it will expect to see impact of its funding over time and an evolution of how we work. So I think we do, over the next year, there will need to be serious consideration about how we become less dependent on some of the existing streams of funding, and how we are positioned to make best use of further funding opportunities will generally be more targeted, particular groups of people or particular models of working. And again, there are separate streams of funding which are less consistent and on a smaller scale around wider vulnerability. And as I say, Herefordshire is yet to successfully tap into those as part of.
Thank you, Ewan. It is a shame that we have to keep chasing funding for such an important area of our care. Any other comments or questions? No, nothing online.
Can I just make one point? Just to reinforce, if I could. Ewan's point. Ewan's always very polite and balanced when he says these things, isn't it? So a couple of 3 years ago, the Home Office were promoting bids into something called the Changing Futures Fund. So you and I had a very quick chat, and as Ewan has said, when it came to making every adult matter, you could have lifted Project Brave, and it would have been me. Similarly, you could have lifted Project Brave and put it into the Changing Futures expression of interest, which Ewan did. I work in a couple of other areas. I work in 4 areas doing a similar role. Herefordshire's was as close to a perfect bid as it could have been, but it doesn't get the money. It never gets the money, and my personal view is the system needs to understand, probably particularly around ex-offenders and folks in contact with the criminal justice system. I think Herefordshire needs to reflect it's never going to attract it. It's always going to go to bigger places, and that is really problematic. One of the adult rapid reviews that I mentioned was for a man who came out of prison. It was anticipated he was going to come out without a home in Herefordshire because the housing duty is not in Herefordshire, but he wanted to come back to Herefordshire. So, I think strategically the system needs to think really hard about what are we going to do about that more difficult group to manage with.
Thanks, Ivan. Any other comments or questions? No. Okay, so what we need to look at is the suggested recommendation, which is that the board considers and comments on Project Brave strategy. Are there any other recommendations, Henry?
There was the suggestion of the renaming of Project Brave, but I don't think that's anything.
Ewan, would you like something in the recommendations regarding that?
On the naming, so I couldn't hear that very well, but on the naming, so the most recent engagement with a variety of people, including with members, we did a political group engagement as part of the cabinet process. We're seeing less and less enthusiasm, to be honest, for changing the name. So unless members of the board feel strongly about that, I'd be happy if that was left off the recommendations.
Anybody feel strongly about it? No? Yeah, we'll continue with that then, Ewan, thank you.
Thank you.
Thank you very much. So we've got no further recommendations to add to that. So is the board content to accept this strategy? Yeah. No problems. Okay, thank you. And again, finally, I've just got to say something to Ewan, because he is also going to be leaving us at the end of March. So another momentous moment. I'd just like to say a big thank you to Ewan from the residents of this county, because you have really supported and committed to the residents, and your expertise and knowledge in this area has been phenomenal, and we will again sadly miss you.
Thank you, Councillor.
Okay, are we okay to carry on, or does anybody need a quick break? Carry on. Just mindful that we've kept Mr. Dawson waiting, and also Athlete here as well. So should we continue? Yeah. Okay, so item 10 on the agenda. We have now got the Herefordshire Inequality Strategy, and this is Alan Dawson, Director of Strategy and Planning. And thank you for your patience, Alan.
No problem at all. Thank you very much for your time. Here today to present the Health Inequalities Strategy to you, and I just wanted to start by thanking particularly the public health team who have helped us drive this, to develop this piece of work. I'll take the report as read. This has been developed by a subgroup of the One Herefordshire Partnership. Contains a number of people actually in the room with you there today. We've engaged a number of partners through this work, particularly our clinician and practitioner forum and the One Herefordshire partners themselves. What the strategy tries to do is link the national approach to reducing health inequalities to the to our local proposed approach, which I'll I'll set out in here. There's a lot of background about health inequalities, which I won't go through. I'll take that as read because I know you've seen that in various presentations in various forms in the past. Suffice to say, health inequalities are widening and have widened particularly during the COVID pandemic. So I'll just leave that bit there. In terms of the national approach, the approach is called Core 20+5, and that really contains three main elements. So the Core 20 is dealing with the most 20% most deprived wards in each area in England. Herefordshire has 9 in that category. And so it approaches that deal with the widening health inequalities in those deprived areas. The plus section is the areas that you want to deal with locally that are specific to your population. And when working on that, we've actually done that as a system with Worcestershire partners, looking at that and agreed an approach there. So the document sets out the 3 areas that we want to focus on, which broadly are about focusing on people that are seldom seen in health and care services. So this is people who aren't registered with a GP. So often we focus a lot on registered populations, but actually there's a cohort of people who aren't registered. And really, this really does link to the previous at least 2 or 3 presentations at this meeting, because a lot of the people that you're talking about there aren't registered with a GP. Rural dispersal is another area, particularly for Herefordshire and Worcestershire, but certainly for Herefordshire, and how we deal with that. And then finally, the final group there that we're proposing to look at in more detail are the Gypsy, Roma and travelling community, who again aren't always registered with our health and care services. So I've covered the Core 20, the plus, so the 5. So the 5 are the 5 nationally mandated areas to focus on around health inequalities. And they are maternity, mental health, respiratory, cancer and hypertension. And if you think about the priorities that this group have set about best start in life and mental health, there's a read across there as well. As part of the work we've done, it doesn't appear in this document, but we have done a huge amount of work before we developed this about what are we doing now, and lessons learned from that. And we found an enormous amount of work that all links towards reducing health inequalities, but actually none of it was coordinated. And the idea behind this strategy is that we give ourselves a framework for addressing health inequalities in the county, and something that brings it all together. So there is an awful lot already happening, which isn't recorded in this document. So finally from me, I just wanted to talk about the objectives in this document. 3 main objectives, why they're in there, why they're important, and what we're doing with them. The first one is around digital and health literacy and improving that amongst healthcare professionals. And what we know from health inequalities, that a big factor in that is that lack of digital and health literacy. Being able to access services increasingly is through a digital approach. And then you've got to be able to understand and respond to what you're being told. And there's a lot of evidence that isn't always the case. So one of the things we want to do is work with our staff, improve their digital and health literacy so they can help the patients and the public and reduce inequalities that way. We want our staff from all the provider organisations to view everything through an inequalities lens. One of the reasons for doing that is to make sure we don't actually make things worse. One of the what we also want to do is make sure staff have skills around digital and health literacy. So the first one's about empowering our staff to do that with the public. The second one is empowering the workforce themselves, making sure that they understand what health inequalities are, how they approach them, and actually also reducing health inequalities in our workforce. Many of us around the table are part of what we call anchor institutions, so some of the major institutions, major employers in Herefordshire that without we would be bereft as a county. And we employ large groups of people, and actually looking at inequalities within our own workforce is something that we can do collectively around that. So there's something around training, teaching our staff to think about inequalities, both for themselves and the patients and the public residents that they deal with. Finally, on here, there's something about reaching our communities. And we're already doing a lot around this. Some really good work in the county, a lot of which is reflected in the plan at the end, linking into existing groups or putting in groups that where, they don't exist. Couple of areas I'd highlight here at the moment is the work of the community partnership led by Herefordshire Health Watch, who've had a focus for the last 12 months on health inequalities and have a number of groups looking at the factors that drive health inequalities and what could be done by partners in the statutory sector and the voluntary sector together around that. The other area are primary care networks, networks of general practice, community staff, social care colleagues working together, understanding the needs of their population and defining some specific projects that deal with the local needs of their population in quite defined areas, in quite defined ways. Often small scale projects dealing with small numbers of people, but the people who invariably use up large amounts of resource or don't use any resource at all, and there are concerns about. So there's some really good work going on that, and a lot of that is reflected in the plan at the end. The plan in the document is not an exhaustive list. I think it very much reflects what we're the sort of main strategic elements of the approach that we've set out in the document for the next few years, but also includes some existing sort of project plan. But really, this just highlights the approach that we're taking around digital and health literacy, working with the population around that, taking away that barrier that drives a lot of health inequalities, focusing on our workforce, making sure that they're cognizant of health and health inequalities and dealing with that in our own workforce, and then thinking about those smaller communities, those projects that we can drive down health inequalities and sort of reaching some of those seldom seen groups. So I'll leave it there. I'm happy to take any questions.
Thank you, Alan. Members, any questions or comments? Yeah, David?
It's not so much a question, it's just, I think it would be good to see some direct reference to the integrated care strategy in the context. Talks a lot about the health and wellbeing strategy, but bearing in mind that tackling health inequalities is such a big part of the wider integrated care strategy. I think we should draw the reference out in the context there as well and establish that link.
Thank you. Alan, obviously David didn't want to be outdone by Hereford, so we'll get the IC, the integrated care strategy, in there somewhere, I'm sure. One question from me is, how and when will we see an evaluation of these objectives on the table?
Sorry, an evaluation in what way?
You know, we've got the objectives, the three objectives that we've got. So we've got the objectives table, which followed on from that. So we've got the aim, the action, the outcome, and the lead agency. I just wondered if we would have how and when we would evaluate these items on here.
Yeah, that's something that we'll take through the Water Herefordshire Partnership and we'll bring back here on a regular basis. I would say, I think health inequalities, it's a longer term piece of work. I would bring something back every 6 months to this group as a report. We have a health inequalities group that meets monthly. And we will be focusing on the plan in here, reporting back up through the Water Herefordshire Partnership into this group.
Okay, thanks. Jane, do you want to add something to that?
I
Or
think-
are you happy to bring it back every 6 months through the board?
Yeah, I was just wondering, Alan, actually, whether we ought to be seeing it, you know, that sort of frequency at the One Herefordshire Partnerships, but perhaps annually back here. That, you say, it is long term. It's not. I'm just wondering if an annual report here might be enough, if that suits the rest of the board.
I think giving it a year is a bit more realistic. Christine?
Yeah, I think I'm wondering if the inequalities group at Herefordshire level needs to have a bit of a refocus on how it works now, because we've so far developed, been focusing on what are we doing already, what would a strategy look like. Feels like we're moving into a new phase, and a lot of the document talks about different agencies' roles in some of the priorities in here, but I think there's a bit further we could go, and thinking in particular about how we utilise our engagement network, which is a group of engagement professionals that could potentially support the priorities here and how we engage our communities on some of these priorities.
So can you narrow that down to a recommendation?
I think my recommendation is that the inequalities group have a focus on is it fit for purpose in its current form? Do we need to think about how it works now we're moving into implementation phase? So at the moment, it could end up being a group where individual agencies are reporting on progress. I feel like we almost need a bit more of a coordinated push on doing work together, rather than just coming together to tell each other what we're doing. Yeah. Sorry, that probably didn't.
It's just for Alan, really. Obviously, with the lead, Alan. Does that sound right to you, Alan?
Yeah, I could completely agree with what Christine's saying. Yeah, and as you said, the group was set up to very much understand what was happening across Herefordshire and define this strategy, which it's done. It needs to move on to a different phase now, and I think will fundamentally look a bit different. So no, completely agree with that.
Yeah, so a couple more recommendations, but the suggested recommendation is that the board receives and comments on this inequality strategy, and then
that we see direct reference to the integrated care strategy in the context of the inequality strategy.
Yeah.
And an annual report comes back to present an evaluation of the three main objectives of the strategy.
Matt?
Thanks, have a really good piece of work. First of all, I think it's great that we've kind of, sometimes inequality strategy can be so broad, it covers everything and anything, from housing to, early births, all those sorts of things, and economy. So I think it's quite good to have some tangible actions. I think that we probably need to think about the resource behind some of those actions. So I think it comes back to our recommendations, and actually, all organisations signed up to those, and we have the resource to deliver, free Wi-Fi in public buildings, for example. I have no idea if there's a cost associated with that. Is that just something we can easily do? So I think we just unpick some of those actions to make sure we can resource them, and we understand the implications for our respective organisations. But overall, I think it's good to have some quite detailed, narrow actions, which can be quite tricky in the inequality strategy. So thanks to you and all your colleagues for doing that.
Thank you.
I think the final recommendation, if I got this right, is that the inequalities group focuses on how it works with engagement, that it needs a more coordinated effort among agencies.
I think it was implementation more, wasn't it? I think, Christine, to your point, not just engagement.
It was 2 points.
Yeah.
Really. It was the how we work with the engagement to work together on some of those priorities implementation.
So I just have one more small point, which was, unless I've missed it, we've got 5 PCNs. There's only 4 with an action on here. Is that because we're just waiting for something from WBC, or?
We'll make sure it's included because WBC's got quite a detailed plan actually, so if it's not in there already, we'll get it in there.
Thanks.
Okay, so just recapping on those recommendations that Henry's just read out. Can we have a proposer and a seconder? The proposer's Christine and Hilary seconding. Okay, so voting members in the room, are you content to accept this strategy? Yeah, thank you very much. Thank you very much, Alan, and thanks for your patience. Okay, so we'll move on now to item 11 on the agenda. And again, sorry for any delay. We have got Christine, no, it's not Christine at all, it's Elizabeth Alte from Worcester. And she's going to be showing us and reporting to us the child panel for the annual report 21-22. And thank you very much for your patience. Welcome.
Thank you. Good morning, everyone. Thank you for inviting me. So this is for the Health and Wellbeing Board. We're asking that the Health and Wellbeing Board receive the Herefordshire and Worcestershire Child Death Overview Panel Annual Report, as the Chair said, for 21-22, noting the thematic learning that's been brought out over the year to prevent future child deaths, and also to support the priorities that are recommended in the report. So just by way of background, there are combined child deaths overview panels. I'll just call it CDOP is the acronym. So following some national guidance that came out in 2018, I think it came out, in 2019, we combined the two counties panels. Previously to that, they were separate. So it's a Herefordshire and Worcestershire CDOP. It's a statutory duty, and the statutory child death partners are Herefordshire Council, Worcestershire County Council, and NHS Hereford and Worcestershire, the ICB. It's an independent multi-agency panel, and its role is to carry out anonymised secondary review of child deaths. So all child deaths are reviewed, every death, whether expected or unexpected, by those professionals that were involved during the child's life or the child's death. And that takes place within 14 days of the death. Then those reports are collated and returned and brought to the CDOP. So it's a secondary review of those child deaths. And the purpose is to identify any learning or any actions that can be done on a wider population to prevent any future child deaths. The panel, when it identifies actions, it monitors those actions, for different agencies, etc. But the annual report is really an opportunity to look at it as a whole and to see if there's any other thematic learning. And one of the responsibilities is also to do this annual report. So just in terms of numbers, it's all detailed in the report, but during that year, there was a total of 43 notifications, death notifications, unfortunately, child deaths of the resident children. During the year, the panel has reviewed 28 cases. Some of the cases take a long time to review, hence that's where the numbers don't tie up. Of those, 67% were expected deaths, so they were within the preceding 24 hours of the death, it was an expected death, but 33% were unexpected and triggered a joint agency response and a SUDIC process. So of those, the purpose of the panel is to look at any modifiable factors, and the CDOP identified modifiable factors in 57% of the cases reviewed. I mean, they are very small numbers, so just with that kind of warning over it. But the most commonly reported modifiable factors last year were smoking and also neonatal care. So it's difficult to draw out specific themes this year because of the small numbers, but what we have drawn out is that there are themes, but we've drawn out sort of priorities. So we'd like these priorities to be continue to be prioritised across the system. So the 4 themes that we've identified, or the first one is prematurity itself. So 10 of those 28 deaths that were reviewed were due to prematurity. The second theme is smoking. So 7 of the deaths identified smoking as a modifiable factor. Another one is around neonatal care, focusing on neonatal care, which is done through the LMNS, the local maternity and neonatal system, but to keep that relentless focus on high quality neonatal care. 5 of those deaths were identified as potentially neonatal care. And then finally, continue the focus on complexity. So 8 of the 28 deaths occurred within real complex, families with very complex situations, complex families, etc. So the 4th one is about to keep the focus on that, to ensure all frontline workers are continued to have training and tools to identify complexity and deal with complexity. The only other thing I just wanted to raise was page 14 in the report focuses on the recommendations from the previous annual report. The previous annual report was 2 years data combined, and there were good number of recommendations that came out of that. So the progress against those recommendations are also in this year's annual report.
Thank you very much, Elizabeth. Okay, board members, any questions or comments for the author?
Thanks. Yeah, I've got a specific question, Elizabeth, about neonatal care and was it access to higher levels of neonatal care than can be provided in the county that was the issue? So level 2, level 3 care, or was it around a deficit in neonatal care that we do provide, which is level 1 effectively?
I can't really answer that question because that's not been, those issues haven't been drawn out, so that the panel doesn't really look at that actually. So I haven't got the details of which level of care that the death took place in. It's just in general of those deaths, it were involved in a number of different issues revolving around neonatal care. So it isn't particularly because it was not in this county or in another county, but it as a whole.
Yeah, I'll put it another way because I think you haven't quite understood me. But within the county, we only provide level 1 special care.
Yeah.
Where because you need a large tertiary centre to provide level 3 care, so effectively intensive care for neonates. So those babies are 23, 24 weeks that can survive.
Yeah.
And so I guess what I'm interested in when we say that one of the factors that can be improved is neonatal care, I'm interested to know whether it's lack of access to level 2, level 3 care that's the issue, or whether the level 1 care that is provided or is in some way not good enough. So, and I accept that you may not have the answer, but that was the question. It's about access to level 2 and level 3 care, and there is a regional review of neonatal capacity that's ongoing. I mean, we will never have more than level 1 care within the county, but we do have difficulty accessing higher levels of care. I mean, occasionally, babies can go as far as Liverpool, Manchester. Because it's not available within the county. So really it's just trying to understand when we say that, what does it actually mean that we want to see improved?
I'm sorry, I'm still not going to be able to answer your question. I do understand the question. So the reviews are looked at neonatal care, the quality of neonatal care provided, whether it was in Herefordshire, whether it was in Worcestershire, or whether it was in Birmingham or somewhere else. So we haven't drawn out individual geographies or individual neonatal units. What's in here is very general. And the issues weren't necessarily to do with access, they're to do with the quality of care in that neonatal unit. But of course, access is potentially a part of that, isn't it? So each individual case would have looked at that, and any recommendations about access to care would have come out of the individual child death review, which would then have been taken forward to the LMNS.
Thanks.
Thank you.
Okay, Matt?
Thanks, Liz, and thanks for joining us today. Really good piece of work, quite succinct as well. It's quite a short report, which is always welcome, I think. Just a quick one, which just crossed my mind, was around the numbers. And I was just wondering, you talked about the achievements, and which is great, and what we've delivered against the achievements. I was wondering if you've actually considered, and whether it's relevant, combining data from previous years to see if there's any trends or commonalities in terms of themes coming through that maybe we can look at. So I don't know if that's been done previously or perhaps something that can be done going forward.
Thanks, Matt. Yes, that's a really helpful suggestion. We did do that previously. I know from Worcestershire, the Worcestershire CDOP used to keep a very, very long tally and keep doing that. And then as I said, last year's annual report brought 2 years worth together, so it was greater numbers, so it was easier to draw out. But that's a really valid point. I'll take that forward, that we continue to do that now as a new Herefordshire and Worcestershire CDOP. Thank you.
Thank you.
Any other questions or comments? So the suggested recommendation that the board receives and notes the annual report. And do we want to add a recommendation, Matt?
Yeah, I think so, just to look at combining data from previous years going forward to try and identify new trends and emerging issues.
Yeah.
Something along those lines. That's right.
Yeah.
Okay, can I have a proposer and seconder for that? Yeah. David, thank you. Okay, thank you again, Elizabeth, and it's good to see you again. I did see you in the Worcester meeting last month, so yeah, every month is you're popping up somewhere.
Thank you very much.
Thank you. Okay, so we'll move on to item 12, and this is the community paradigm. This is something that is completely new to me, and I think Hilary is going to talk us through it. Thank you, Hilary.
Yes, that's a big ask, but I shall do my best. I guess in answer to the question you haven't yet asked me, Chair, which is why now? So this whole concept of community paradigm is really starting to take hold. It came out originally from a report from New Local, which is an independent think tank, and I guess takes our initial thinking around community development, community involvement, community empowerment onto the next level. And it's something that we're beginning to have some quite detailed conversations about in Herefordshire, so I wanted to bring it here as the start of the journey, if you like, and I think it will come back to future meetings. Essentially, community paradigm, and I think we've seen it woven through all of the reports this morning, is about taking what we currently do onto the next level, as I've said, is more thinking about how we work more with communities, but on an equal shared basis of power, how we think differently about funding. So at the moment, our relationship, if you look at particularly with voluntary and community sector, is very much in that commissioner sense. So we commission, we ask the community sector to provide, and we hold them to account against a fairly rigid set of outcomes and indicators. There's nothing wrong with that. That's what we've done. But actually what a community paradigm says, actually we move more away from that. We start to look at different models of funding that respond more to local needs, because inevitably when we commission at that higher level, it's probably more at a county level, or at best perhaps at a PCN level. What community paradigm starts to get us into conversations around this is responding to very local challenges, very local needs. And potentially, as we talked about Project Brave this morning, that might be about different funding models to support particular cohorts of people with complex multiple vulnerabilities, for example. Probably got those words in the wrong order, but you know what I mean. So I think this is exciting, I think. I think it takes us into a different conversation. It builds on all of that strong work that we already have in Herefordshire, which is very much about being about communities, about the strength of communities. But I think takes us into something that talks about how we harness that strength in a very different way, in a way that empowers communities, in a way that's about equal power shared between statutory and community. I'm sure Christine will have plenty to say, but so this is very much at that early stage of bringing it. I think if you think particularly around prevention, I think there's a lot we can do by shifting our ways in which we fund, by thinking more about those outcomes we want to deliver. the issues around evaluation, which I'm pretty sure is also on your list of questions, Chair, obviously becomes more challenging in that arena, because we're not holding a rigid commissioning, we're not holding a rigid set of performance indicators. And there's some of the things we've got to work through. As I say, we're at the very start of this way of thinking. I think it's exciting, and I think particularly in Herefordshire we have the basis from which to work that through. We haven't got all the answers, but I think we've got we're at the start of that conversation, and I think we've got a lot of good stuff in place on which we can build. And I think one of the particular slides in the pack which talks about shifting from that top down and more of that bottom up, I don't think it's an either or, because I think you probably have to have a bit of a mix, but it is much more saying actually it's got to be more of a balance there than what we're currently doing. So as I say, it's very much at the start of this. I'm very happy to share the document that this is based on with the board. I think that will probably give more a bit more background to it, and certainly I found it helpful in terms of just my thinking around it. But we are looking to do some more work over this over the next couple of months, and I would hope that when we come back to the Health and Wellbeing Board, its first meeting in the new municipal year, we can probably bring a bit more clarity around where we're going with it and what some of the implications are. I'm happy to try and take questions, or really to prompt a bit more of a discussion, really. I'm sure Christine, without putting her on the spot, which I have just done, will probably have things she wants to say.
Thank you, Hilary. I think the most important thing is local challenges, local need, and obviously Talk Community Programme is one of our key steers in all that. Any comments or questions from members? Did you want to say something, Christine?
Yeah, I think from the community's perspective, what we've been hearing a lot over the last 2 years of setting up the community partnership is a real desire to do more and work in partnership with statutory functions. But we haven't really got the right approach and mechanism to do that well. And I think the fundamental idea of the community paradigm is we shift how we do things, which is quite a cultural thing, as well as potentially changing the way we fund things, the way we have conversations collectively. And a lot of the upstream things that community often see themselves playing a role in, funded or otherwise, doesn't always sit squarely with one statutory body. And I think there's a role we all play in some of these functions. And I think when we work individually in our commissioning silos, if you like, we won't necessarily get the best solution. Whereas I think coming together to collectively look at what are our challenges, how do we solve them, and coming up with that solutions-focused way of doing it together is probably how we deal with some of those shared collective accountabilities.
Thank you very much. Any other comments or questions, David?
I'd just like to flag and put on record, we absolutely support this from an ICB perspective. People have seen in the draft integrated care strategy that will come to the board in April as well. There were 8 partner commitments, of which number 5 talks about working as equal partners with voluntary communities and the sector. So absolutely support it from an ICB perspective. We're really keen to get involved and work with you on it.
Thank you. I think one of the things you mentioned, Christine, was about breaking those silos, which is really important. We need to work together. Any other comments or questions? Nobody on the virtual world either. Okay, so the recommendation is that the board considers and comments on this paradigm presentation, which I think we've done. We will be sent the document. I think, Hilary, you're going to do that, and we'll come back to the board when? I know it's the new year, but
I think whenever the first meeting is in the municipal year, I think we should give an update there.
Okay, an update in the first meeting, yeah. So just to remind us of those new recommendations, please, Henry.
It's just that with the community paradigm, that we bring the document back in the first meeting of the new municipal year.
Lovely, and I'll propose that, if I can have a seconder. Christine, thank you. So are board members content to note these recommendations and the document? Yeah. Thank you. I think we'll move on now to item 13, which is health protection. Now, this is something that we've never brought to this board before, and it's to comment on the reestablishing the Health Protection Assurance Forum. And we have Rob Davies. I see he has appeared. Yes, he's in the virtual room. So, Rob, it's over to you, please.
Thank you, Chair. Can you hear me okay?
Yes, thank you.
Fantastic. So thanks for receiving this report. It's a short one, and I realise that you've had plenty of meaty items, so I'll try and keep it brief. And you're right, this hasn't come to the Health and Wellbeing Board for about 3 years. So part of this is about addressing that issue. So it's about the Herefordshire Health Protection Assurance Forum, which has a role to, clues in the title, assure that a range of health protection functions across Herefordshire are in place and working as they should. And this is a function that sits under our DPH, our Director of Public Health, Matt, who's in the room with us, and ideally would report into the Health and Wellbeing Board. So it covers a large breadth of health protection functions, which might be worth just touching on. So not just, for example, flu and COVID, it goes all the way through to screening immunizations, environmental health, control of chemical, biological and radiological hazards, other sorts of, risk management and project planning, hospital infectious diseases, hospital acquired infections, and activity in care homes. So the breadth of the functions reflect also the range of the organisations involved. So it's public health in the local authority, it's environmental health in the local authority, UK Health Security Agency, our NHS partners and others. So the idea of the forum is it brings together that range and complexity and understands the risks across the system and provides that prodding and poking to say, is what we've planned and got in place working, functioning and robust? Now, the formal meetings of that forum were actually paused in 2020 because the majority of the health protection workforce, staff and capacity was redeployed at short notice to tackle COVID, and that remained for a number of years. So a benefit of that was that actually the working relationships and some new working relationships really were forged tight and fast across the system in attempts to specifically address that single issue of COVID infection and protect our residents. And the downside is the flip side of that coin, which was that we then did less around the broader health protection work, including some of the preventative activity like adult screening and childhood immunizations. And the key point here is that without a high performance across the full system, we will be storing up risks that will be realized in the future. So as we regained a little bit of control during and through COVID in the summer of last year, summer of 2022, we decided that it was a good time to re-establish the forum with a specific remit to kind of re-establish the broader focus than had been present over those few years for obvious reasons. So that was a logistical challenge of just re-establishing relevant and revised terms of reference, updating memberships of the key organisations, many of which had changed, moved on or changed remit, re-establishing the sort of data flows and information to ensure that we understand the risks and situation across system, and reviewing our performance, started to review some of our performance against a range of measures, comparing ourselves to England, our region, and other local authorities similar to our own. So that's sort of our attempt to re-establish and reintroduce the forum to this group. And we have a bit of planned activity that we'd like to share with you and is for note. Namely, a big deliverable this year will be an annual report. which again hasn't happened for a number of years. The value of that is to do that more systematic and rigorous assessment of where we are, data informed, evidence led, but also what our partners on the ground are telling us about their experiences, for example, in hospitals, in care homes, are they robust against infections, etc. And then sift through that information and get some real key priorities as a result of that are unique to Herefordshire that we should be focusing more of our energies on. So because of different information streams, that's probably going to be most useful, and I'm proposing that we bring that to board in the autumn winter of this year. That will provide, we'll have more relevant information at that point in the year effectively. And just finally to note that a screening immunisation will also be a big focus of ours, namely because I believe you've been introduced to the draft health and wellbeing strategy earlier today. So one of the two priorities there is giving children the best start. Part of that is ensuring that they are robust against infections that are completely preventable, but otherwise have serious consequences in later life. So we are going to do a bit of a deep dive into that to ensure we're rock solid in where our priorities should be as a system. So yeah, it's a short report for comment and feedback. Thank you, Chair.
Thank you, Rob. I think we've had no worse time for being challenged on this over the last few years, have we? So, you've been very busy people, and I look forward to seeing the annual report as soon as you can get that one done. Matt, did you want to add anything?
No, recognising it's a new area for the board, but I think it's a really important one, as we've just kind of witnessed for the last 2 years.
Yeah.
And again, I think it goes through, health inequalities, community paradigm. It kind of threads through all of that. So again, I think there's some system issues that we can address as a board to help maybe push up those areas where maybe we're not performing. So I think an annual report is probably proportionate to come here and unplug any issues. And as Bob says, it links to the Best Start in Life as well for the immunisations programme. So we fare relatively well across the county. There's always room for improvement in terms of maybe uptake in certain areas which we could improve. So no, thanks to Rob for taking this work forward.
Yeah, thank you. There's definite golden threads there, isn't there, that have gone through everything we discussed this morning. Members, questions? Councillor Toynbee.
Yeah, thanks for this. This isn't a cynical question at all. I'm just interested in why we need this as well as public health or whatever it's called now, UK HSA and this board, why do we need this as well?
So there's a statutory function for me to, as a Director of Public Health, to ensure that we have all the prep plans in place in terms of immunisation and screening. We're working effectively together as a system. I think the UK Health Security Agency do some good work. They are regional and national, and they are part of this overall forum. But I think at that local level, I think we need that assurance and the coordination. I think there's still a lot of work going through in terms of the role of the UK HSA as well, in terms of what their function is being. And we're working through an MOU with them actually in terms of, as we kind of exit the pandemic, if you like, who's actually responsible for what. The other thing we need to be aware of is immunisations and screening is going to be delegated through to the Integrated Care Board from 2024. So we're having conversations with the Integrated Care Board in terms of actually how do we then deliver immunisations and screening at that local level. So I think there's going to be an increasing role for local delivery of this, Councillor Toynbee, and we need to work that through.
Okay,
facial expression means I haven't answered the question.
No, you have. I'll keep thinking about it. There are just so many boards and forums and panels and everything, aren't there?
You're right, and I have got a governance diagram which I'm working with Alan Dawson on, and it'd be good to bring to the board, because one of the things we talked about, isn't it, is how we rationalise some of these boards. I mean, this is just a quarterly board, so you feel it's proportionate in terms of the needs. But I mean, if there's one of the things we can do that's strongly evidence-based, is immunisations and screening. We just know it works and can save lives as well. So it's a fair challenge. We can take that one away, but personally, for my professional role, I think it's needed in my duties.
Okay, thanks.
And I think it's really important to note table 2, where it shows us how we do as a county against national statistics, because even though it's not brilliant, it's better than a lot better than average national. Any other comments or questions?
Just a couple from me. The bit I didn't quite understand on the terms of reference was the PRR responsibility. So is that specifically in relation to infection prevention? It's not the broader emergency preparedness and resilience.
I'll go to Rob on that one, because I think one of my questions is how it interfaces with the local health resilience partnership. So Rob, do you want to come back on that one?
Yeah, there's different interpretations. So the list of the functions comes from a best practice guide of what should be in there. So I think there's different interpretations of that. We're interpreting that it does, particularly because, for example, in a local authority, a local authority point of view, we're lucky to have emergency resilience in our public health team, so we know their plans. But in terms of wider organisations, we're not assuring that their plans are up and running unless we've done them together, if you see what I mean. So there is a bit of a grey area. It's a good question. But for example, that would come out because we've got representations of each of the major organisations. So if we're talking about resilience against a major flood or a different pandemic, then the right people around that table to say, oh, well, I'm not sure our organisation is tight on that. Maybe we need to talk to the relevant colleagues I guess
that's that almost makes my case actually, because from Wye Valley, you've got the consultant microbiologist who would have no other role in emergency planning resilience. And I think we've got a number of forums for that. So for me, it doesn't feel like it belongs to this. It's very specifically related to the other terms of reference. Otherwise, I think it's just too blurry. And then my second point was about representation. So there's the third one down is Head of Operations and Partnerships, which I think was Hazel Braun's title 3 years ago. So that's so John Barnes is in that role now, but obviously has a different role. And in terms of fulfilling the requirement, I don't know if John would be the right person and whether you'd need somebody else. I don't know what you think, Matt.
I'll have a conversation offline, Jane, and just see who's the most appropriate person. I agree, like emergency planning, I think that sits with the HRP. Let's have that conversation about who's the most appropriate person.
Yeah. So I don't know if there's somebody else that did. And I guess the other one was the screening immunisation lead, and you've got there NHS England, but suggesting that's going to come.
At some
point.
Is
going to come down. Is that next year? I think.
24, I think.
So
it's coming over sooner. Screening is going to be slightly later, from my understanding.
So we will need to modify the operating model to connect those things.
Yeah.
I think I know who the most likely person to lead that would be. Probably Catherine Sinclair, ex-Catherine Larkin, who led all the COVID stuff. She's in that space. You're right. It's not.
I don't think it's John.
It's not John. Yeah. And it would be more appropriate for Catherine, but I'll confirm that to you and I'll come back on it.
So out of that, are there any other recommendations that we need to add? Because at the moment we've got for the board to receive and comment on the re-establishing the Health Protection Assurance Forum report.
Approve?
Yeah.
Yeah.
All those in favour? Thank you very much. Right, item 14, which is the work programme. So I've not got anything on that, so do you have a slide or something on this?
Yeah, it is on the very last page, isn't it, on the...
I'm going to go back to this. Thank you very much. Okay, so we are at March the 13th, so the next meeting will be the 27th, when you've got the DPH annual report, the strategy, health and wellbeing strategy, sexual violence strategy, and David with the integrated care strategy. Then I think then May we're looking at another workshop or equivalent. I think that's
we don't have anything down for that workshop.
Specific,
so we might want to utilise that perhaps to the development of the health wellbeing strategy delivery plans at Civil Needs. That's just one idea, but I welcome the board for further thoughts.
So one of the things I mentioned earlier, we've got to do this thing called the Joint Forward Plan, which is an NHS kind of delivery plan. Health and Wellbeing Board has a defined role in that of giving an opinion on the extent to which the Joint Forward Plan addresses the Health and Wellbeing Board's priorities. So we'll need to spend some time probably in a development session and then maybe the June meeting actually signing off that opinion before it then gets published at the end of June with the Joint Forward Plan.
So that may be a May agenda item. And then we've got June, the Children's Improvement Plan, Health and Wellbeing Board delivery plans, mental health strategy collaborative, One Herefordshire update, CSP update, area strategy, domestic abuse strategy, and then September, Health and Wellbeing Board report, Better Care Fund, and then December, it's back to Matt and the Health and Wellbeing Board report, probably.
Yeah, I think the intention was to put a bit before plan together, it says in itself, isn't it? But we talked today about the community paradigm, we can add that one to it, the health protection assurance annual report. So I think it's just trying to think ahead, so we have a structured work plan, and then the plans around the health and wellbeing strategy will help around that. So it's very draft, it can obviously change as things emerge, but welcome input from others if you feel other things need to be.
Yeah. Christine?
I'm just wondering about the Children and Young People's Partnership that's newly established. How will that feed in and when would be appropriate?
Yeah, so Children and Young People Partnership will be charged with developing the plan for the Best Start in Life priority, and I know they've got a workshop at the end of March to start shaping that plan, so we just need to think when it will land at the board, so we just need to give that some thought. Christine, you're absolutely right, that will need to come back.
Any other additions? I think it's really important that we have that forward plan, Matt, and I thank you for your work on that. You know, you're all busy people and we need to get those dates in the diary. As you can see today, we haven't had everybody in attendance, so I think, you know, forward planning is the way to go. Okay, so that's that one, and item 15, any other business?
Sorry, it's just related to that, it's just we haven't got that, and I think it's really what you said. We haven't got any dates after the April one. We do need to get them in the diary, don't we? And then we can have that meeting beforehand to be clear about the agenda and set the agenda. So I think if we can have them, I mean, you know, if we're saying it's going to be quarterly, we could almost set them for the next 2 years now, couldn't we? We can, you know, we're clear and everybody can get the diary sorted out.
And that's over to you, Henry. Thank you very much. Yeah, so finally, any other business? No, nobody on there. Okay, so item 16, this is the next scheduled meeting is the 27th of April, and that is from 2 till 5. And I hope that you all have a good afternoon now, and I formally close this meeting.